Okay, so let's look at the next rhythm, which is ventricular tachycardia. So dangerous rhythm, right? So this rhythm is originating within the ventricles themselves. Nothing to do with the SA node, AV node. This is a rhythm that originates from ventricles that are irritated. So what could make a ventricle irritated? Well, how about a heart attack, a myocardial infarction that's injured the nervous system within the ventricles and has also um, damaged and uh, the myocytes have some myocytes have died, right? So with this, the electricity gets stuck in a loop going around the ventricles extremely fast. Okay, and uh, the body has a hard time breaking this rhythm because of this electrical circuit going around the ventricles. And this is a dangerous rhythm. Some patients will not survive this rhythm. They may not get to the hospital because of decreased cardiac output and hypotension, right? So some patients will survive it. So there's two different types you can think of. So ventricular tachycardia with a patient that still has a pulse, and VTAC that's pulseless in the patient. Okay, let's talk about the first one, VTAC with a pulse still. So it means that there's still some cardiac output, but the patient may still be hypotensive. They may be confused because of decreased perfusion to the brain. They may be having chest pain because the heart is beating at 180, 200 beats per minute or faster. So let's look at the treatments for VTAC with a pulse still. Okay, so they're not really that different. You'll see when we talk about pulseless VTAC. So in VTAC with a pulse, we could try a vagal maneuver, but we're not going to try that for too long because it doesn't have a high success rate, and we really want to get the person out of this rhythm. Okay, we can try an antiarrhythmic, such as procainamide or amiodarone. But remember, those take time to go in. They're intravenous, they take time, and we're watching this rhythm on the monitor, and the patient is very likely hypotensive, and if they're not, they may become hypotensive. So most of us will just cardiovert. So we'll put the pads on, and we'll try and, if we have time, we'll sedate them and give them pain medication, and we'll cardiovert them with electricity. Okay, so antiarrhythmics are an option, but just in general, we tend to go to cardioversion just to get them out of this rhythm very quickly. Okay, pulseless VTAC. So we see VTAC on the monitor, they're pulseless. Well, that's going to mean they don't have a blood pressure either, and which is going to mean they're unconscious typically, right? So we treat this like there's no cardiac output. So we're going to immediately defibrillate, okay? And notice we're defibrillating here, and I'll talk about that on a later slide, instead of cardioverting. So we defibrillate. If that doesn't work and the rhythm continues, we do CPR, so chest compressions for 2 minutes. And then we try and defibrillate again. If that doesn't work, we go right back to CPR and we administer an IV dose of epinephrine. And after 2 minutes, we defibrillate again. If that doesn't work, we put in an antiarrhythmic and we do 2 minutes of CPR, and on and on and on. So epinephrine will actually give every 5 minutes IV. The antiarrhythmic will typically only do twice. So we'll give the amiodarone on 2 occasions, okay? And then no matter what happens, we're not going to repeat it, okay? So the overall goal with ventricular tachycardia is to get the person out of this rhythm, and that's why we're putting in amiodarone, okay? We could actually, now we give epinephrine every 5 minutes. Why is that? Well, epinephrine is a powerful vasoconstrictor. So during CPR, it's going to help maintain blood pressure because it's really vasoconstricting the peripheral capillaries and arterioles. Okay, let's look at the rhythm at the top left there. So that is ventricular tachycardia. So what's happening is, as I said, the ventricles are stuck in this electrical loop. Those are all QRSs that you're looking at. Okay, so those wide, peaked, they look like mountains. Those are all QRSs, one after the next after the next. Okay, they're not being stimulated by P waves, nothing to do with the normal conduction of the heart. Okay, and they're wide because the rhythm is starting in the ventricle. So it has to go from myocyte to myocyte to myocyte, so it takes a long time. So it's wide. So we call it a wide complex rhythm. Okay. So it's fast. Typically, it's greater. Invariably, it's greater than 150. It's regular because the electricity is stuck in that loop. There's no P waves because it didn't come from the SA node. Okay. So I hope that helps with the understanding of VT. Okay, so ventricular fibrillation is just as it says, just as it's described. So the ventricles are basically just fibrillating like a bag of worms. Okay, so there's no cardiac output. There's no organized contractions of the ventricles. There's no QRSs, and there's just a little bit of electricity occurring from the ventricles, but there's nothing coordinated in terms of electricity or mechanical contractions. Okay, what causes ventricular fibrillation? Usually it occurs because there's been ischemia to a ventricle, or there's been an infarction that then triggers this electrical storm to occur in the ventricle. Okay? Remember, there's no cardiac output, no blood pressure, the patient's unconscious. So what do? Well, it's going to be almost identical. It's going to be identical to VTAC with no pulse, right? That series of defibrillation doesn't work, CPR. Defibrillate doesn't work, CPR. Let's put some epinephrine in. Defibrillate. If it doesn't work, CPR again. Let's throw in an antiarrhythmic such as amiodarone. And we just continue that. And again, we can put amiodarone in twice, sorry. But we give the epinephrine typically every 3 to 5 minutes. Okay? And one of two things is going to happen. Either there's going to be return of spontaneous circulation, meaning we got a rhythm back on the monitor and we got a blood pressure and a pulse back, or the cardiac arrest is called and time of death is pronounced. Okay. So ROSC on the slide here is return of spontaneous circulation, meaning while we were doing this algorithm, CPR, defibrillate, we got a rhythm back. Okay, and typically when you get a rhythm back, you get a pulse back because the cardiac output returns. Okay. So when you hear of someone having a heart attack that then suddenly collapsed on the road, they didn't die because their heart, the pumping of the heart suddenly just all died. They died because the heart attack created ventricular fibrillation. And ventricular fibrillation completely eliminated any cardiac output. Okay, so it's the electrical disturbance that occurred after the heart attack that made them drop on the road. Okay, or wherever they were. Okay, so asystole is just what it describes, right? So asystole, no contractions, and not only no contractions, no electricity to the heart. Okay, so you're not going to see P waves or QRSs or T waves. It means that there's actually no electricity occurring that we're picking up on the chest lead, on the leads. So really the treatment for this is CPR and epinephrine because there's nothing to defibrillate. There's nothing to shock. So we'll do CPR, epinephrine, and just continue the CPR until by chance we get a rhythm back, or we call the code and pronounce the patient dead. Okay, this obviously has a really poor prognosis, asystole. Okay, every once in a while someone gets a pulse and a rhythm back with asystole after we've done good CPR and epinephrine, but it's rare. Okay, and it's usually someone who's collapsed in the hospital as opposed to being 30 minutes away and the ambulance are now bringing them in, and there's not much we can do. We can continue CPR and epinephrine until we decide that the patient's dead. Okay, so pulseless electrical activity. So we have a patient in front of us who has no pulse, they're unconscious, they have no blood pressure, but we look at the monitor and we can see some kind of rhythm still occurring in the electrical system of the heart. Okay, so this is where at the beginning, we spoke about don't look at the monitor first, look at the patient. If we were to look at a monitor sometimes, well, the monitor is not necessarily going to tell us the blood pressure, the pulse, is the person awake, is the person unconscious? So look at the patient first. So sometimes the electrical system lasts longer than the actual pumping of the heart. Okay, especially say for example we've given epinephrine. Epinephrine is a very powerful stimulant to the heart, and it can continue the nerve stimulation and nerve impulses longer than the actual heart is pumping. And that's why we may see it on the monitor, when in actual fact there's no contractions of the atrium and there's no contractions of the ventricles. Okay, so what can we do? CPR and epinephrine, and we can continue CPR and epinephrine. There are some reversible causes of pulseless electrical activity. I'm not going to get into them now, but I'm just going to give you one example. So cardiac tamponade, where the heart is being compressed by fluid in the pericardial space, and the chambers can't fill with blood. There's no cardiac output, but the electrical system is still working in the heart. Okay, so there are a couple of things that we think of that could be reversible, but for the most part, pulseless electrical activity has a really poor prognosis. And while we're doing CPR and epinephrine, we're thinking, okay, what are the reversible causes that I could potentially help this person with? Okay. Okay, so let's just do a recap of rhythms. Okay, so this slide isn't going to help us with seeing if there's a heart attack, such as ST elevation or ST depression or hypertrophic T waves, nothing like that, just the rhythm of the being generated by the heart. Okay, so the question at the top, is there a P wave? So let's go to the left side. Yes, there is a P wave. Okay, is the P wave always related to the QRS somehow? Is there some relationship with the P wave and the QRS? If the answer is yes, it's sinus rhythm, right? So P wave QRS, P wave QRS, P wave QRS, well, that's sinus rhythm. P wave prolonged PR interval, but still a QRS. P wave prolonged PR interval, still a QRS. That's still sinus rhythm, but with a first degree block, right? So always ask yourself, is there a P wave associated with the QRSs? That's the first question you need to ask yourself with rhythms. Okay, so let's start on the left-hand side. So yes, there's a P wave that's associated with the QRSs. So what's the underlying rhythm? Sinus rhythm. Now let's go down the left arm. So is the PR interval normal, meaning less than one large box or 0.2 seconds? If the answer is yes, you're done. You have normal sinus rhythm, assuming it's between 60 and 100. If it's less than 60, it's sinus bradycardia. If it's greater than 100, it's sinus tachycardia. Okay, let's look at still the bottom left. The PR interval is longer than 0.2 seconds or one large pink box. Okay, you still have sinus rhythm, but it has a first degree block. So we would still call it normal sinus rhythm with a first degree block, okay? Because the underlying rhythm is still sinus rhythm. It's being generated by the sinus node, okay? Okay, let's go back up to where it says sinus rhythm. And let's go over to the question, are there P waves always related to the QRS? And we'll say no, sometimes. Okay, well that's where you have your secondary blocks, right? So second degree block type 1 or Wenke back, well, you have a P and then a QRS, and then a P and a gradually prolonging PR interval, then a QRS, and then a P, and then oops, dropped. It dropped QRS. Okay, so that would be a Wenke back. Still normal sinus, it's still sinus rhythm, but it would be sinus rhythm with a second degree type 1 block. Okay, let's stay with second degree blocks. So a P, a QRS, a P, a QRS, a P, and then poof, no QRS, absent. Okay, that's a second degree block type 2. Okay, what's the rhythm? Sinus rhythm still, because it's coming from the sinus node, but there's a second degree block type 2 or Mobitz type 2. Okay. What about the next one? Third degree block. Okay, so we can see P waves going through, but they're not associated with the QRSs at all. They're still being generated by the SA node, but they're totally blocked at the AV node. So you can see P waves marching through the whole rhythm strip, and you can see a very slow rhythm of QRSs, and they're being generated by the ventricles completely. That's a third degree block. Okay. Let's go to the top again, the middle one. Is there a P wave? And the answer is yes, I think I see P waves. But there's lots and lots of P waves. Well, if there's lots and lots of P waves, typically around 300 per minute, that's typically atrial flutter. Okay? Let's go over to the far right. Is there a P wave? No, there's no P waves. Okay? So there's no P waves. What should I think of? Well, let's look at the QRS now. Is it a narrow QRS? So if it's a narrow QRS, it means it's still using the nerve fibers of the heart, and that's what makes it narrow. It makes it fast, right? It goes down the bundle of His, splits into left and right bundles, goes to the Purkinje fibers, and that's an extremely fast way of depolarizing the ventricle. So the QRS will be narrow. Okay. Is it irregular with no P waves and the QRSs are narrow? Okay. That's atrial fibrillation. No P waves, very irregular, and typically a narrow QRS. Okay. We won't focus on atrial or junctional rhythms. Okay, let's go down the middle one. No P wave. What about the QRS? It's wide. Okay, what does wide mean? Well, it can mean that the electricity is beginning in the ventricle itself from myocyte to myocyte to myocyte. It's not using the fast nerve bundles for conduction. So that's a ventricular rhythm. If it's really, really fast, we'll call it ventricular tachycardia. Okay. We're not going to talk about the aberrant ventricular pathway. Okay, let's go to the far right one. Okay, there's no P waves. What about the QRS? I don't see any QRSs. Okay, that's bad news, right? So that means if I'm not seeing any QRSs, there's no regular depolarization of the ventricles. So that's going to be ventricular fibrillation, or if it's a completely flat line, that's going to be asystole. Okay, so really figuring out rhythms starts with the P wave. Yes, there's a P wave. No, there isn't a P wave. Okay, and then you follow it from there. So, I mean, as you get used to this, it actually is a lot of fun to do this, and you can get very, very good at it. And you can determine a rhythm very quickly once you practice this. Okay, I hope this helps.